Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Whenever I'm thinking about interpreting MRI imaging, I always like to start with some idea of the biomechanics involved, and ground reactive forces is the name of the game for metatarsal and plantar plate tears. How much time we spend on the ground, how much pressure, what inclination, what degree of pressure does that metatarsal head feel will tell us something about the ability of its structures to withstand those moments, forces, and vectors. So in this case, the diagram is well laid out by Kirby that the plantar fascia contracts against the plantar plate. And if this reverse windlass mechanism is working, it should pull the toe down to the ground. And that will enable you to toe off and propel yourself forward. When I'm thinking about how to apply any of what I see or I'm seeing a case, it always helps if I go to a site that I love. Radsource has been a great boost for education. And I think that these clinics and these small chapters that show a general case really have helped me a long way in understanding. So in this case, they give you an example of a 56-year-old female with gradual onset of forefoot pain. And you can see that this MRI through the forefoot is showing some pathology in the region of the plantar plate. As we've come to see, we can see that there's some subluxation or incongruency of the second. And we'll take a look at the findings as they explain them to us. And we can see that direct, complete discontinuity of the plantar plate here. We can see this discontinuity of the proper portion of the collateral ligament and that medial toe deviation, widening, or what's called splaying between the second and third, and they give it that diagnosis. So Radsource is wonderful, and I really think that the illustration here hits home that anatomy we talked about. If we looked at the third metatarsal head and we understood that deep to the head, there's that thickened plantar plate, relatively speaking, about 2 millimeters in thickness, about 2 centimeters in length, about 8 to 10 millimeters in width, connecting to the accessory collateral ligaments, which are invested superiorly dorsally by the proper collateral ligaments. That deep transverse intermetatarsal band separating out that region of the flexor tendon from the neurovascular bundle. So these articles and illustrations help us to understand some of the complex anatomy that we are up against when we're trying to understand how the metatarsal ground reactive forces are affecting this entire complex. Generally speaking, after reviewing this, we've seen that we're going to be looking for that U-shaped structure, looking at the flexor tendon, again, looking at the accessory and the proper collateral ligament and the collateral ligaments. I really like Radsource because it also goes to explain not only complete tears, but partial tears, which can be subtle and showing as this focal fluid intensity on stir imaging in that case. This, a complete tear of the lateral proper collateral ligament with that medial deviation, and that splay finding we'll take a look has been written up. If you see a dislocation, definitely means that you've had a plantar plate tear, and it can even be a very thin plantar plate, so you may not even see it. Again, gives you some guidance to the clinical diagnosis and management and helps us to understand how the clinician is actually stressing this. And these features here can help us understand how we might better serve our clients and patients in ultrasound, where we're doing a lot of this dynamic imaging. In looking at some of the great original work that's done in this area, I really learned a lot from this predictive MRI correlates of lesser MTP joint tears by Ullmans and Elsinger. And this, they looked at control cases of different reasons why the forefoot would have some kind of pain. They separated all the different reasons out. They looked at patients who had plantar plate tears, and they looked at some of the features that are associated with plantar plate tears. And they did some interesting things. And I think this is biomechanically what leads us to some of the problems. And they were looking at the rotational axis of deviation. Now, if you've been in any of my classes, you hear me talk about flattening of the forefoot parabola. And there are different ways we can flatten the metatarsal head, these lesser metatarsals, can rotate towards the great toe. And when it does that, what it's doing is a forefoot varus. So basically, it's supinating the forefoot and moving the forefoot into that varus position. Oppositely, we can see that the great toe is coming in this medial direction in a pronating stance. And so they looked very interestingly at the convergence. So they found that when the great toe, the pronation moment and the supination moment, when it was greater than 45 degrees of an axis of rotation, that was an issue that predisposed the patient to plantar plate tears. And they also looked at just this rotation, but I think they found it to be too tedious to actually measure it. But I think it's an observation that we can make, and it might be helpful for the clinician to understand that in the neutral position, when the patient's laying in neutral position in our magnet, that this is the general rotation of the axis. This might also help to explain why more commonly the tears are on the fibular side of the plantar plate complex, often affecting the interosseous membrane, the lumbrical, that whole complex, and the lateral aspect of the plate. Of course, they also talked about splaying of the toes, the second and third being a predictor, a secondary sign that you might have a real issue regarding the plantar plate. And also, again, looking at that eccentric pericapsular fibrosis. And that was one of the most important additions to the literature, the differentiation between what it meant to have a pseudoneuroma and what it meant to have an interspaced neuroma. And it's important to differentiate. They point out that it's particularly problematic as treatment varies dramatically and misdiagnosis and mistreatment can cause prolonged pain. And forefoot dysfunction is something that we encounter clinically over and over again. So I think adding to it would be to add in the MRI some of the features of what we're seeing. And I simply state this out as metatarsus adductus, or rotation of the plantar bases towards the great toe, just to give an idea. And I do talk about the forefoot parabola. Furthermore, they looked at many different indicators as to sensitivity, specificity, and accuracy of these indirect MRI features in detecting plantar plate tears. So they looked at things like dorsal subluxation, pseudoneuromas, proximal phalangeal bone marrow edema. And this is a great article out of AJR from 2017, second and third MTP plantar plate tears, Yamada and their group. Amazing work that really, I think, put plantar plate imaging on the map as something that you will find most radiologists reporting whether or not the plantar capsules are intact, and picking apart that you need excellent quality in order to see these structures. So having slice thickness of 3 and 4 millimeters, as we've talked about in the lecture, and having a smaller field of view, the field of view being on the order of 8 to 10 centimeters, and not trying to take in the entire foot, are parts of your clinical excellence and putting into your imaging so that you can get images that with clarity show the plantar plate as a structure invested into the proximal phalangeal base, looking at the flexor tendon here, the U-shaped structure helping us to pick out where the flexor tendon and tunnel is with regards to the plantar plate, the accessory collateral ligament and the proper collateral ligament, that thinner band. Furthermore, giving us excellent demonstrations of what it meant to have this pericapsular eccentric soft tissue swelling that we can see here. If we dropped and bisected that midline, we can see that a portion of this eccentric pericapsular fibrosis is hugging this metatarsal head, and that's indicative of the pseudoneuroma sign. And we can contrast that to a neuroma where there's a central thickening of the interdigital nerve. It's still considered pericapsular fibrosis, but it's more global, and it's felt to be compression against the deep transverse intermetatarsal ligament. Furthermore, they propose a grading system that really helps us to understand that tears less than 50% partial tears, and that's very common. You'll see a lot of that. And the kinds of tears that you for sure want to pick up would be 3s and 4s, where you're certainly seeing involvement not only of the tear, but also secondary structures, now collateral ligaments, beginning to show signs of instability, right? And of course, buttonholing tears, where the metatarsal head is moving through the plantar complex. Furthermore, direct features, they outline clearly for us partial or complete discontinuity, seen in 13 out of 34 patients. Thinning, these are other signs. So thinning of the distal insertion, non-visualization of the plantar plate was something that was occasionally seen. Any change in the morphology, so morphologic changes were present in all of them. So having that sensitive eye to detect may help us to start to see these tears at all. Of course, I leave this for you to evaluate because I think everything in this article is important, including the imaging, which helps us to find this interosseous tendon thickening. This is an earlier sign that I see very common in patients who have early plantar plate dysfunction. Notice the pericapsular inflammation. In this different patient, they're showing us that plantar plate proximal phalangeal distance line. And they again talk about the association between those indirect features with plantar plated surgery. So almost all of these patients that had a pseudoneuroma sign had a plantar plate at surgery. And interosseous tendon collateral ligament complex, many of them also had that. So being able to identify these features with clarity will help us to stratify our patients. And when we look at where this becomes important, I really think that this particular chapter that puts it together for us at MR imaging of the plantar plate, that normal anatomy, turf toe, and other injuries, they go through the entire constellation of forefoot imaging. And I suggest for anyone in the business to really be picking apart this. They go through all of the anatomic features that I've started to describe, the different shapes of the metatarsal heads, the great toe being larger and the second metatarsal head being taller rather than wider, and what these features mean. And just to skip down to things like that are occurring at the lesser plates, we're looking at that crossover deformity, giving us excellent pictures clinically to help us with our MRI read to understand what we're trying to do when we're moving that classification system to help our clinicians. Again, those examples of a full dorsal dislocation. In this article, again, reviewing for us some of the features that might predispose us to plate tears at all. Having second metatarsal head protrusion may indicate that there's a greater driver of the metatarsal ground reactive forces. So things like this may predispose the patient or may be indicating that we indeed are having more pressure on a plantar plate. These are normal examples. They move to abnormal examples, this being a normal sonogram and this being the abnormal, the hypoechoic region of the tear in this area of discontinuity of the plantar plate seen on ultrasound. So they give us an idea of what we can see. But what is really the power of this article is it also brings a lot of the clinical portions home by talking about the treatment and what we can do for our patients. So where in the past they did not have great surgical techniques, now they have restoration techniques of joint function, soft tissue transfers, and reconstruction that can really help stabilize these lesser MTP joints and are showing to have greater success. But what we can do is help them to understand what is the degree of dysfunction that the patient is showing on the MRI by looking at the metatarsal parabola, letting them know about the ability of a head protrusion or their goals, helping them to reduce pressure under the metatarsal head. What do we see on the MRI to help alleviate that? Does the patient have a pes cavus or different things like that? And so I think that these great articles that I presented between the original articles, Radsource, and understanding the biomechanics really help us to hit home and impact the treatment outcomes for our patients with forefoot pain. Thank you. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.